Another reason of such changes from DSM-4 to DSM-5 is because OCD tends to wax and wane, while hoarding patients usually have an early onset, and the symptoms are getting worse in lifetime. Symptoms usually appear in adolescents during their teenage years, and patients start to get impaired by the symptoms or feel distress in 30s and receive treatment upon discovery in 50s. So it shows that hoarding is chronic. Wax and wane here means the intensity of OCD symptoms usually fluctuates greatly. Even if one seems better, it is simply a part of the course of the disorder. The patient may relapse again after the presence of the seemingly good phenomenon. Let's talk about generally what hoarding disorder is. Patients feel difficult persistently to throw away their belongings regardless of their values, and this causes distress because they assume everything has the same value, but actually it is not. We know that different items have different values. We may treasure something more while something less. Therefore, hoarding patients keep everything in a place. Patients can over-acquire things by keeping all their possessions, as well as purchasing excessively, over-collecting, or over-stealing. Diagnostic criteria and features. Just like what I've mentioned, A. Feeling hard persistently to throw away all belongings they have. Actually, it does not have to be the difficulty to throw away something, but by all means to leave the excess actively, no matter it is through selling, recycling, giving away, or any other possible methods. They feel difficult because B. First, they feel they have the need to save the items. For example, they feel a newspaper that was printed 10 years ago was still necessary because there was still information that was seemed to be important, useful inside, and they should not miss that. Another example is that if they accidentally touch something, they perceive they need to keep it to avoid others from being contaminated by touching the possession the individual has touched already. The second reason is they feel distress in discarding them, and therefore C. They store things at active major living space, such as the living room, bedroom, kitchen, etc., instead of some peripheral regions of the house, such as the garage, balcony, etc. The original intended use of the active areas is given up to clutter those possessions. DEF. Hoarding causes impairment, distress in different areas of their lives. If hoarding is a consequence, symptom, or an effect of other medical conditions, then it should not be diagnosed as hoarding. Moving on to the specifiers. XXS acquisition. Individuals feel difficult to discard their hoarded items given that they acquire too much items or there is no available space. Research shows that 80 to 90% of hoarders have no available space for them to store their hoarded items. Next, three types of insights. Firstly, good or fair insight. Patients recognize such behaviors and believe that they are annoying. Secondly, poor insight. Even if patients are mostly convinced that they have such behaviors, they do not regard them as problematic. The last one, absent or delusional insights. Patients are entirely convinced that their behaviors are not problematic, not causing any troubles. Differential diagnosis. If the symptoms are the direct consequences of these disorders or features, then patients should not be diagnosed as hoarding disorder. It is important to note that OCD patients are not usually warranted as excess acquisition, not because they do not really over-acquire things, but third parties intervene the situation, such as the family or even the government. One possible reason for government or authority intervention is that the case raises environmental concerns. The environment there is not hygienic. Same as here, if the symptoms are the direct consequences of these disorders or features, the individual should not be diagnosed as hoarding disorder. A report reviewed a case that a male adult hoarded for 20 years after the death of his only son. We could see that there was a comorbidity of hoarding and depression. Associated features. Indecisiveness. It is a temperamental prognostic factor of individuals with hoarding disorder and their first-degree relatives. Individuals cannot decide which item to leave, which is also associated with difficulty planning. They do not have a plan on how to deal with the challenge to discard their less useful possessions. They have deficits or problems in organizing the task of discarding their items, associated with task organization. Also, they have difficulty deciding what's useful or not, so they keep things longer than others and avoid leaving things, and this is associated with avoidance. As a result, when they are forced to throw away or give away possessions, they still cannot choose what to throw away or not, which is associated with distractibility. Perfectionism. Discarding things gives them a sense of incompleteness, so they are not willing to discard things. And they keep things. This action provides them with an ideology of perfection, completeness, and it is associated with perfectionism. Animal hoarding is another specific type of hoarding. Animal hoarders fail to provide minimal standard of living conditions for animals, such as sanitation, ventilation, and disease, death, veterinary care. They usually hoard objects too. Animal hoarders are found to have the poorest insight and usually live alone. As we can see here, people living in these areas even have the difficulty to cook or sleep in bed. As a result, the life quality of hoarders decreases due to poor hygiene, risk of having a fire, and health issues, weaker social relationships, and more conflicts with others arising from the hoarding habit of the individual. It also affects daily activities, causing distress and impairment.